Thank you, Malcolm. So there are four substantive pieces of business that we will be discussing this morning, in addition to our usual focus on operational performance. The first is the outcome of the spending review, which was announced on November 25th, 5 days after our last public board meeting. The second is the publication of the mandate to NHS England and the wider NHS, which has been laid before Parliament this morning. The third is the principal item of business here, which is the allocation of £560 billion of public spending to the National Health Service over the next 5 years. And fourthly, the work that is going on with our partners, the other national leadership bodies of the NHS, for the NHS planning guidance, which we expect to be able to issue within the next several days. So taking those in turn, on the outcome of the spending review, as you'll see in my Chief Executive's report here, and has obviously been widely reported in the media, we judged against our request for a front-loaded settlement, have clearly achieved that. £3.8 billion of real terms growth for the National Health Service next year. In effect, 3/5 of the 5-year funding will have been delivered in the first 2 out of the 5 years. We've got some very substantial funding pressures in the system that have to be dealt with next year, and the pensions costs, the 1.8 billion for a sustainability focus that was set out yesterday, a part of that. Those are all part, frankly, of the reasons why the front-loaded nature of the settlement was not only welcome, it was necessary. We, at our annual general meeting, however, talked about 4 other tests in addition to the front-loading, and I think it's worth for the board just describing our assessment as to where we have landed on those. In addition to front-loading, the second of the tests was ensuring that there was a syncing up of the requests that would be made by the government of the National Health Service with the phasing of the extra funding year by year over the 5-year period. And my judgment is that the mandate published today, in terms of the affordability of the asks for 16-17, corresponds to that, with a broad set of goals for 2021. Obviously, there's a discussion about precisely what the sequencing looks like over the rest of the Parliament, but we've effectively got a U-shaped funding settlement, front-loading and back-loading. And so, as we think about logistically what the rollout of some of the workforce and other developments, including 7-day services and hospitals, we will have that U-shaped funding settlement in mind. Thirdly, we made the point that we need a realistic and deliverable set of efficiency expectations, particularly through the traditional provider tariff mechanism. And I think we've arrived at a situation where just slightly less than half of the much discussed £22 billion, slightly under 11 billion, will have to come from that source. And there is wider action that the Department of Health, government, national leadership bodies will need to take. And in fact, we now have a clear and detailed description of those efficiencies, and the government will be making announcements on elements of those shortly. However, there were 2 other elements to the 5 tests that were outside the immediate bailiwick of the National Health Service. One of those around prevention and public health, and there were continuing funding cuts in local authority finance public health services on the back of the spending review. So my judgment is that we need to see concerted action from government, both nationally and in terms of new powers for local government, manifest through the new childhood obesity strategy in the new year, for example, in order to be able to say that that test would have been met. And on the 5th of our 5, we made the point that the level of demand facing the NHS is obviously a function of the availability of social care. And there were, as I say in my report, some welcome moves to hypothecate new funding streams through the precept, through a funded expansion of the Better Care Fund and other mechanisms. But nevertheless, even with that, there will still be, as the Local Government Association, the Association of Directors of Adult Social Services have pointed out, a widening gap between the availability of funding and the need for social care. And if that's not addressed over the remainder of the period through 2020, then that will result in extra demand over and above that which was modelled into the 5-year forward view. So that's just a statement of fact. That's not a controversial statement, I don't think, but I think it's important that as a board we understand how we've landed on those 5 tests. Allocations is obviously what we're going to spend the bulk of the time talking about today. Paul will walk us through that. I would simply underline the fact that we're seeking to do 3 things, I think, with the allocation recommendations before the board this morning. First, we want to provide the wherewithal to stabilise performance and fund the implementation of the forward view. And we are proposing doing that with the creation of a sustainability and transformation fund to the tune of 2.1 billion next year, of which 1.8 billion would principally be to do with the financial pressures in the National Health Service, the sustainability element, if you like, 300 million, 340 in fact, to continue with vanguards and expand some of our work on implementing the forward view in 16-17. But more importantly, the transformation fund would grow from 2.1 billion next year to 2.9 billion the year after, reaching 3.4 billion by 2021, and an increasing share of that expanding transformation fund available for the implementation of the new care models, the paradigm esteem on mental health, the technology and other investments that we want to see. So the first theme is stabilising performance and funding the forward view. The second theme of our recommendations is ensuring that we've got reasonable funding locally, with our thumb on the scale, particularly for primary care, and also ensuring that every CCG is getting real terms growth, while recognising that there will continue to be funding pressures in specialised care, particularly next year, as Paul will establish for some of the new hepatitis C drugs. That's something not in our discretion that we can't ignore. And then thirdly, continuing a strong push that this board has made since its creation, ensuring that we use the allocations process to contribute to inequalities reduction. And you'll recall that this time last year, we managed to reduce from 34 to 17 the number of CCGs who were more than 5% below their fair shares, with the commitment to seek to deal with the remaining 17 this year. The recommendation before you would get every CCG no more than 5% below its fair shares, not just for CCG commission services, but for the first time also taking into account the total healthcare usage of their population. So CCG services, but also primary care and specialised services. And then over and above that, for the first time, putting in an explicit inequalities adjustment for specialised commissioning spend, and making substantial progress in the fairness of allocations for primary care services that Paul will describe. So in a nutshell, stabilising performance, investing in the forward view, local funding that enables people to make their plans work, and action to cut inequalities. Those are the recommendations before you. I would also just mention in this context that with the leadership of Paul and colleagues, continuing progress in our devolution discussions across the country. So as part of this package, you'll see we are recommending that we reach agreement with Greater Manchester on a carved-out, ring-fenced settlement for them. In addition, I, together with the Chancellor, the Mayor of London, the Health Secretary, launched 5 integration pilots across London earlier in the week on Tuesday, and have met with my colleagues, the leaders of councils from the North East, to talk about the health agenda that they are keen to pursue, and we're wanting to work with them on. But I think we also need to recognise that this board established a clear set of criteria that we thought should be applied to genuine efforts to decentralise or devolve funding, and we need to make sure that those are rigorously applied. And frankly, where there are problems about that, we should call a spade, as we have done recently, in fact within the last week, in respect of Kernow CCG in Cornwall, where we have had to issue legal directions. So the prospect that they would be in a position to take on substantial extra delegated or devolved powers, I think they've got a lot of work to do before we could imagine that that would actually be real. And then you'll see from the other activities section of my report that, as usual, a range of frontline engagement, joint work with NHS Improvement, including 2 face-to-face meetings of all Trust and CCG chief executives that Jim Mackey and I held a couple of Fridays ago in Leeds and London, which is very important. And in fact, we held a joint NHS England, NHS Improvement meeting of our regional directors to talk about place-based challenges across the country yesterday afternoon. So, Malcolm, any questions, of course, but I think that's, to some extent, setting the table for the substance of the discussions we're about to have.
Well, thanks, Simon. Let me extend his invitation to the board for any questions, comments on the Chief Executive's report. Right.